So I'm Tolga Sursal. I'm a neurosurgeon who now is doing predominantly just spine surgery. That includes all types of spine surgery, but this talk is about lumbar spine surgery and how to make the right choice. In a sense, it's a good focus for how to talk about the clinic visit, different patients' problems, and how we approach making those decisions together. Um, this is just a little bit about me before I go on. This is a picture of my family, who I'm grateful for, and really glad to be able to do what I do. And they make it possible, and they bring me a lot of joy at home. I went to medical school at Eastern Virginia Medical School, and then after that, I was in neurosurgery residency up in New York at Westchester Medical Center, New York Medical College, and spent 7 years there, and then went to the University of Virginia for a neurosurgery spine fellowship. And then I was practicing in Charlottesville for a couple years before coming down to Virginia Beach. So I actually grew up in this area, and this is sort of a homecoming for me. And it's great to be able to bring a lot of my family back together. So I'll start just by introducing low back pain. This isn't a topic, this isn't a lecture that's focused on all of low back pain, but it's a very common problem. And lumbar spine surgery deals with a lot of different patients who have different versions of low back pain and leg pain. So, low back pain is a leading cause of years lived with disability worldwide, and it results in a loss of over 100 million days of work per year and a diminished quality of life. And the costs are enormous. These numbers probably low because this was data from several years ago, but it's over 100 billion a year annually in the US alone. And then there are increasing costs associated with low back pain are continuing to rise every year because we have an ever aging population. And the reason that these are some of the reasons why it's so important, but up to 80% of people experience significant back pain at some point in their lives. And chronic low back pain affects about uh, a fifth of adults worldwide. So this is a very common topic, and whether you end up needing surgery for low back pain or leg pain, it can affect your life in some way. The picture is just to show you how many different places where back pain could be coming from and why it can be sometimes hard to treat back pain with surgical intervention. And sometimes just hard to even pinpoint where the pain generator is, where the source of pain is coming from. So, common causes of low back pain, you can see this is a little bit of a laundry list. Poor posture, sitting, standing posture, sleeping positioning, bending forward too long, even kind of that classic hiking your shoulder to your phone receiver, excess weight, whether from pregnancy or obesity, sudden or strenuous physical effort, including accidents and injuries from sports, falls, especially in the elderly, improper lifting of heavy weight, or even normal amount of weight with improper technique, carrying a heavy purse, briefcase, or backpack, stress and muscle tension, lack of muscle tone, just deconditioning, lack of exercise. And some important ones that aren't mentioned in this list, but can contribute to some of the things we see on the picture over here are nicotine use, which can lead to disc problems and therefore back pain, and also osteoporosis, which can lead to worsening of, you know, you can get injuries such as spinal fractures or just have worsening of your arthritis or lead to structural problems such as deformity or spondylolisthesis or scoliosis, which we'll kind of go into some of those words a little bit later, what they might mean. But basically, osteoporosis and nicotine aren't on this list, and they can contribute to a lot of sources of back pain and leg pain. So, what is sciatica? And people always come and we talk about pinched nerves and sciatic pain, back pain. Well, the sciatic pain comes from the sciatic nerve, which is kind of has contributing fibers from a number of different nerve roots in the lower back. But as it passes out, it goes down the back of the leg, through the buttocks, and that pain that radiates along that sciatic nerve is what we call sciatica. And it's not always sciatica, from every single one of these nerve fibers that you have. It could just be a single nerve root. For example, excuse me, um, if you have a disc herniation, you can see it's just pressing on one of those nerve roots as it's coming out of the spine. And so sometimes you can have a single nerve root that presents as sciatic pain, pain running down the back of the leg. Causes of sciatica can be the kinds of things that are listed in this picture, which was pulled from the New England Journal and in an article about sciatica. You can have spondylolisthesis or slippage of one bone on another, and that could lead to pinching of the nerves or instability, which could lead to pain from the spinal nerves. The disc herniation with a pressure on one single nerve root. You could have foraminal or central canal stenosis, where there's just narrowing of the space for all of the nerve roots, or perhaps narrowing for individual nerve roots as they're coming out of the spinal canal, going to the rest of the body. A synovial cyst, which the synovial cyst grows off of the joint, the capsule of the joint, and can press on the nerve, just as a disc herniation can. And some rare ones like piriformis syndrome, which is where the sciatic nerve gets pinched between the piriformis muscle and the bone as it's passing out of the pelvis. So there's all sorts of reasons for why you might have sciatic pain, and some of them are more related to the spine and things that we can treat with surgery. So I just like to talk here about what visit to the clinic is like. When you come in to the clinic, it can take some time to get in to see a specialist about your back. Perhaps you've seen a primary care doctor, or you've seen the emergency department or an urgent care physician. And then you've been maybe prescribed some pain medications or physical therapy, maybe gotten some imaging, maybe you have no imaging. And so when you come in, we talk about the history of your present condition. How long has that pain been going on for? Was there anything specific that caused it? What type of pain are you having? Where is the pain? Is it in your back? Is it in your legs? And then we do a physical exam. We test your strength and your sensation and your reflexes, from specifically when it's low back and leg pain, we test your legs, obviously. And I'm trying to key in on which nerve roots is the pain distribution in, and where is there numbness or tingling or abnormal sensation in the legs? Is it in one of these nerve root distributions? And the reason I look for that is because that keys me into what I can do to help you with surgery. So we review your imaging. If you don't have any imaging, we usually get you an x-ray at the clinic that day, and often with what's called flexion extension views. That just means we have you bend forward and bend back, and it lets us see if there's any excess movement in the lower back, in the spine. A CT, if it's available, is often needed for surgical planning. So if we've looked at an MRI and decided you need surgery, we'll often send you for a CT scan so we can see the bones very well to plan for surgery. An MRI is usually needed to make an accurate diagnosis and a surgical decision for lumbar spine surgery. And that's because it shows us what X-rays and CTs don't show well enough, which are the discs, the nerves, the soft tissue, and whether there's any pinched nerves or anything that we can decompress with surgery or we can stabilize with surgery that may benefit you. And then we talk about non-surgical and surgical options, and we discuss together what your treatment plan will be. And in spine surgery, more and more these days, the surgery plan and the treatment plan is tailored to the individual patient based on your particular condition, what's going on anatomically in your back, and then what your symptoms are and your experience of those symptoms, and then your personal goals on what you'd like to achieve. Here's a list of non-surgical options, and these are pretty important, as I'll show in the next few slides, why we harp on trying all of these options before surgery. Of course, you have pain medications, and these fall into a couple different groups. Analgesics are things that are tended to treat the pain that you're having, and Tylenol is one of them, or acetaminophen, and non-steroidal anti-inflammatories like ibuprofen, naproxen, or meloxicam. Opioids, they're not a great long-term solution. Often they're used as a short-term solution for intense pain. But if you But if you start using them chronically, it becomes a problem. That's also true of NSAIDs. If you take ibuprofen or meloxicam for too long, you can get GI issues or other issues with your kidneys, liver, for instance. Muscle relaxants are often prescribed, and sometimes they're helpful. It's usually the most helpful if you're having associated muscle spasms with the pain that you're having. And then neuropathic pain medications. These are meant to treat nerve pain specifically. And I've talked with lots of patients about gabapentin and pregabalin because they specifically treat pain from the nerve or abnormal sensations through the nerves. There are other ones like duloxetine or amitriptyline. I don't prescribe those as often, but those are other medications that treat neuropathic pain. So if someone has a bad experience or can't tolerate gabapentin or pregabalin, we often switch to an alternate agent. Other non-surgical options include activity modification. This has got good and bad things about it. First of all, if certain types of activity are triggering the pain or making you, um, uh, suffer or have abnormal sensation, or in some way it's causing you grief, then we often modify that activity and don't do as much of it. And this has a drawback of maybe affecting your quality of life. Maybe those are activities that you really want to be doing that you're now not able to do because of this pain or um, abnormal sensation that you're having. Physical therapy is really important for a couple of reasons. One, sometimes some physical therapy is all you might need to get over the pain that you're having. And I've sent many people to physical therapy and they come back and they say, well, now I'm able to cope with the pain. Working through some of the pain with my physical therapist really helped me overcome it or manage it, control it, or cope with it. And now I don't feel like I need surgery. So that's a common conversation that I have. Sometimes the physical therapy makes things worse. And going to physical therapy and going through that process helps you learn what kinds of movements are triggering the pain, what makes the pain worse, and what can help it get better. Um, and the last thing is often, as it's one of these non-surgical options, it's one of the things that insurance companies ask you to participate in before you start getting advanced imaging and or surgery. And there's good reasons for that because often some round of physical therapy does help many patients get better. And so we haven't tried it. It often, um, then we might be operating more than we actually need to. So other non-surgical options include pain management or pain intervention. And these are epidural steroid injections, facet injections, radiofrequency ablation in as a second part of those facet injections, if that's helpful for you. And epidural steroid injections are meant to target a specific area or nerve which might be acting up and causing some of the pain you might be having. And so it serves two purposes. One, it can be relieving of the pain. It can also be diagnostic and help us confirm that that's the area where your pain is coming from. So even if we get short-term relief from epidural steroid injections, maybe a day or two or a week or two, that's some confirmation that that area was where that pain was coming from. And they can help us make a decision about where to operate or where not to operate. Or if you're feeling better, of course, then that was the whole point of this exercise of doing non-surgical options anyway. Facet injections are mainly for back pain from the facet joints, the joints between the bones of the spine. And by injecting around the area of the spine, we can test to see if that's where there's inflammation or arthritis. And if that helps, those injections help, you can try ablation where they burn the sensory nerves to the joints and then therefore have a more durable effect on the back pain that you're having. Alternative therapies are also available, such as massage therapy, chiropractors, or acupuncture. And then there are other surgical options, which are sort of interventional options. They're not full-on surgeries, but they are somewhat surgical. Spinal cord stimulator placement, vertebroplasty, kyphoplasty. They're sort of out of the scope of this talk, but there are other non-surgical options that you can try. So one of the reasons we emphasize non-surgical options is because of cases like this. This is a case that was presented in the New England Journal of a resolution of a lumbar disc herniation without surgery. As you can see, it says a 29-year-old lady who presented to the spine clinic with new onset pain in her right leg, accompanied by paresthesia, or abnormal sensation. And then they showed in the picture on the left, lumbar disc herniation. And so that was the source of her pain in her right leg. And then there's also significant stenosis of the spinal canal. And she went for physical therapy, injections of steroids, glucocorticoids, and then 5 months later got another MRI and shows the MRI on the right. And this happens. It doesn't happen all the time. It would be nice if it happened more frequently. But sometimes, if you are able to control your symptoms with conservative therapy, your disc, acute herniated disc like this, can heal itself. Now, not all conditions can heal themselves like this. And when you see me in the clinic, I will often talk to you about whether this is something that may get better with time and conservative therapy, or whether that's not really likely to happen based on the natural history of what your particular problem is. But many conditions like the acute herniated disc can have this natural history. And so we often try to do conservative management. And if you can get things under control, then avoid surgery in this way, because this might happen. But how to choose whether to go for surgery or not? And this is another article that talks about who needs back surgery. And one of the lines here was pretty telling to me, so I included it here, is that it's not a final common pathway for everyone with persistent back pain. And when you have surgery that's sort of outside of certain specific types of situations, we get disappointed patients if we treat them with surgery. So how do we choose? This is another reason why this is another article about persistent low back pain. If it's just low back pain and not leg pain or pain with pinched nerves involved, then it used to be treated much more frequently with spinal fusion, with screws and rods to stabilize the level that we think the pain was coming from. But as I showed you before, there's many different places where the back pain can come from the muscles, from the joints, from the discs, from the bones. And so when we were treating patients with spinal fusion for just back pain, there was about 50-50 outcomes of after treating with fusion. And you can see here, after 1 year, 22% of patients in fusion group returned to work as compared with a third of patients in the rehab group. And then in a larger trial, they showed excellent outcomes in 16% of people versus 2% of people who had spinal fusion versus an unstructured physical therapy program. But at 5 years after the surgery, there was no clear benefit of the fusion. So that benefit kind of disappears with time. So that kind of asks some questions like, should we be fusing everybody for persistent low back pain? It's not a great treatment for back pain. It's a much better treatment for leg pain and pinched nerves. And so which situations is back pain best treated with surgery, and which situations are best treated with therapy, which conservative therapy? And those are the kinds of conversations we have in the clinic to talk about your condition and what might work. Here are just a short list of different surgical options. This is by no means exhaustive, but it does sort of encompass many different ways you can approach dealing with problems. And it really depends on what the patient's individual problem is. Microdiscectomy, which you take out a small disc herniation, and I'll show you an example of that. And then decompressive laminectomy, where you remove the bone, the ligament. A foraminotomy, where you open up one of the channels where the nerve comes out of the spine. Resection of a synovial cyst, where there's a cyst that's compressing the nerve instead of the disc herniation gets resected. Stabilization and resection of tumor, where you actually stabilize the spine and separate the tumor from the nerve roots and from the spinal cord if it's at that level. And that gives room for chemotherapy and radiation to treat the tumor without injuring the nerves so much. We often call that a separation surgery. Interbody fusion, where this could be from the side or from the front or from the back, but where we remove the disc and replace it with a spacer and some bone graft and help heal the bones together. Multi-level fusions, which is obviously it's just many levels of the same thing. And revision surgery, where somebody's had a surgery, they have a new problem, and now you're required to revise the old surgery to incorporate the new problem. So I'll just talk through a couple cases here. And then we'll sort of maybe show a couple different examples of how we make the decision for treatment and what kinds of situations are treated with surgery very well in the lumbar spine. So this case was a 34-year-old female who presented with low back and leg pain, and it just came on spontaneously. And then it kind of got better, but then she slipped down some stairs and it really flared up. She was having ongoing pain in the left low back, left buttock, and left posterior thigh, left lateral calf, and the sole of her foot. So going all the way down the back of the leg, down to the foot. And it was like an electric hot poker-like sensation. She had 3 sets of steroid injections. She had tried some physical therapy, which just made her back pain worse. So it was aborted and she failed physical therapy in that sense. And she was on gabapentin, which is a nerve pain medication, and Baclofen, which is another muscle relaxant. And then she had a diminished sensation in the left S1 dermatome, which goes along the back of the leg down to the bottom of the foot. She had lost her ankle jerk reflex on the left side, and she had weakness of the left plantar flexion, or pushing down with your foot. And this is what we found on her MRI. And it was a large herniated disc at L5-S1. And if you can look over here, the right and left are flip-flopped. So this is the disc pressing on the left-sided nerve at L5-S1. So it's the S1 nerve root as it's passing by and about to go out at the next level. This nerve root out here already is the L5 nerve root, but the S1 nerve root's right here next to this disc, and it's about to go out at the next level down here. And this is actually one of the cases we like to see because it's a patient that we can really help in a big way, make them better faster, and get them feeling great. The recovery is pretty quick. Surgery recovery is good. And basically, immediately after surgery, you have a lot of relief of symptoms in most cases. This is what typically happens during surgery for that disc. You know, we tried all the conservative therapies, pain medications, injections, physical therapy, didn't work. And now we end up, she has some weakness, especially that was what was concerning for her, and the loss of reflex. And so we took her for a microdiscectomy. And in the microdiscectomy, we put you on this Wilson frame, which is this arch, and it opens up the spaces in the back here. We kind of open the spine on one side so you can see the bones L4 and L5, and then in her case, it was L5 and S1. And we drill a little bit of a hole so that we can see the sac that carries the nerve roots, the thecal sac, and the nerve root that's passing by. In her case, it was S1. In this case, it's an L5 nerve root. And the disc that's material that's herniated here. We sort of cut and grasp and pull out that disc fragment, and you're out of the hospital the same day. And she had immediate relief of her symptoms. She saw us again at 6 weeks after the surgery. She had mild back pain, just some soreness. And especially when she was doing household work or chores, she had some soreness in the back. Otherwise, her leg pain was significantly improved. Sensation mostly returned to her foot, some minimal persistent numbness. And numbness and tingling can be the most troubling sensation to improve. And that can take many, many, many months, like 9 months to a year for that to get better, if it's going to get better at all. And it can be troubling, and sometimes it's just persistent even after surgery. At 6 months after the surgery, minimal back pain. She didn't have any left leg pain, minimal persistent numbness in the left foot, and very tolerable. And she was very happy with how things went. So we removed that disc, and she did wonderfully. Basically, by 2 to 3 months after the surgery, she was at her new normal, and then that was it. These are 2 different articles on why we treat, whether to use conservative treatment or surgery for sciatica. And it basically shows that at 1 year, outcomes are similar for patients who receive either conservative treatment or surgery, but recovery is faster for those with early surgery. So if your symptoms are so severe, it's very reasonable to do surgery to get you better, to get you back to work, to get you back to your life quicker. Once you've kind of waited out 6 to 8 weeks, just to try to see if it gets better initially with some conservative therapy. And if it hasn't gotten better, then you can try surgery to get it better faster. Or you can wait if it's not that bad and see if it gets better with time. but people tend to do fine with conservative treatment over the long run. This next article down at the bottom shows that if you have sciatica lasting 4 to 12 months, that sciatica lasting more than 4 to 12 months was still that using microdiscectomy was better than non-surgical care with respect to the pain intensity at 6 months of follow-up. So this shows something a little bit different than the other one, which was showing at 1 year, that if the pain is lasting 4 months, you have much better outcomes with microdiscectomy than leaving it alone. So it's reasonable to try some, sorry about that. It's reasonable to try conservative therapy for a while, but after a certain point, if it hasn't gotten better, it's very reasonable to go for surgery because you'll likely have better outcome than if you don't. This second case is a case of lumbar spinal stenosis and neurogenic claudication. I'll just explain kind of what that neurogenic claudication is. And it is a common symptom that people have if they have lumbar spinal stenosis, meaning if there's narrowing of the spinal canal that pinches the nerves. So this was a 73-year-old lady who had chronic low back pain for several years with many compression fractures in her spine. She had had a kyphoplasty, some cement placed into the bone to treat one of those fractures. She was having persistent, non-radiating low back pain, mostly on the right side, and she had bilateral leg weakness due to severe pain when she was upright and walking around. She would get neuropathy in a stocking distribution in both of her legs. She tended to lean forward and had difficulty straightening her back upright without severe pain. She'd been taking pain medications, doing physical therapy, but it wasn't really making any difference. She also complained of leg tightness when she stood or walked, which completely resolved with sitting down or leaning over a countertop. And that's pretty classic. The specific sign we usually talk about is leaning on a shopping cart to make your back feel better when you're, or legs feel better when you're in the store. That's a sign that there may be some spinal stenosis. It's pretty classic for it. And then she had no back pain at rest and no bowel bladder incontinence. Had normal strength at rest, but had some diminished sensation in both legs. And on imaging, there were these two levels of spinal stenosis here at L3-4 and L4-5. And you can see that where there should be an open canal, actually this area right here is just the only space where the nerve roots are allowed to be. They seem trapped in here. And that was what was causing the symptoms. This is kind of a picture that illustrates what happens as we stress our back, as we use our backs over many, many years. We get arthritis in our joints, and that tends to make these joints grow larger. The ligament that spans behind the sac that carries the nerve roots gets thicker. There's bulging of the disc, and those all serve to narrow this spinal canal. You can see how open it is in the normal version and how narrow it becomes in spinal stenosis. And so the treatment we usually do is what's called decompressive laminectomy. And this is one example of it over here at the top, where you remove the bones, you drill the bones out in these areas, and you remove that bone and the ligament that's stretching over the sac. And it gives the nerve roots that had this kind of configuration, maybe more triangular, this rounded configuration gives them more room. Now, sometimes you can just do the laminectomy. Sometimes you fuse, but in a decompressive laminectomy alone, the point is just to do the bony and ligamentous removal. Spondylolisthesis is when there's a slip. And even in those cases, if there's no instability, meaning if there's not excess movement when you do the flexion extension x-ray, you can do just the laminectomy. This shows in some cases where people do the laminectomy and then they put some bone graft down the back to help those layers heal together. So this patient, we did a decompressive laminectomy on at those two levels, and at 6 weeks was improved from the surgery with less back and leg pain and had some persistent sensation, diminished sensation. At 6 months, there was further improvement of low back and leg pain, improved walking, could walk like, a couple miles without any difficulty, and then had some persistent diminished sensation in both legs. And again, at 6 months, it's still early days for that diminished sensation, but it's possible that that can last, you know, longer or be just persistent forever. Um, One way to treat that would be with nerve pain medications. And then this is a randomized controlled trial of fusion surgery for spinal stenosis. And it just says that patients who did decompression plus fusion did not do any better than patients who did decompression surgery alone. So I have many patients who actually, we talk about whether to do fusion or not fusion at the time we're discussing whether we're doing this decompression. And really, only in those cases where there's dynamic instability is it really make a lot of sense to fuse it up front, although it's not necessarily wrong to, because many of us have done laminectomies and then had patients afterwards come back and actually need the instrumentation. And so it's hard to know which patients are going to fail. That's why we do the flexion extension x-rays. But it's sort of a warning to all patients we do a laminectomy on. This sort of thing may happen. You may need to get an instrumentation at a later time if you still have persistent back pain or there's restenosis. But initially, it makes a lot of sense to just choose the decompression alone. The next case is a rather quick one. It's similar to the very first case with the herniated disc, but it's something called Cauda-Equina syndrome. The reason I talk about it is because in both of the first two cases, they were not having bowel or bladder incontinence. And in this case, or retention. In this case, it's a 36-year-old female who had 3 weeks of severe back pain after lifting a heavy box at home with excruciating bilateral leg pain and weakness. And she had 1 to 2 days of perineal or numbness around your private parts, and inability to void for the last 12 hours. So this was a surgical emergency because of this retention of urine and the weakness that she was having in the lower extremities. So she was 3 out of 5, meaning she could only really raise her knee. She could extend her knees only to anti-gravity, and then her left ankle was weak. And then this is a post-void residuals, how much urine's in your bladder after you go to the bathroom. And so that was high, and therefore she needed emergent surgical decompression. And this is the outline of that disc. And you can see it's kind of crowding all of the nerve roots, and that was what led to her symptoms. So the surgery is the same thing as a microdiscectomy or a decompressive laminectomy with a discectomy, but basically you have to open up space around those nerve roots and decompress them. And you want to do this as soon as possible. So whenever somebody comes in with spinal stenosis or a herniated disc, we always warn patients that if you have loss of bowel or bladder function, or you have profound weakness or intractable pain, so that to the point where you can't get up and walk around, then that's more of a surgical emergency or urgency, and we need to go to the OR. In this particular case, when it's Cauda-Equina, when you have when you have anesthesia, like numbness around your groin, and you have bladder symptoms like this, it's suggested to go to the operating room within 24 hours. And there's data that shows that if you're operated within 48 hours, you have good resolution of your symptoms most of the time. And there's other data that says as long as you're going within 72 hours, it's a good idea. But there is data that says you can even have improvement up to 1 to 2 weeks after the onset of these symptoms. But it's just much better the sooner you get in there. And that's what all the data says. So if you start having these symptoms, you'll probably be sent to the emergency department to get this taken care of right away. So this patient on post-op day 1 had great pain control. The extremity strength was back to normal. Her legs were back to full strength. And she had 50% improvement of her symptoms of numbness around her genitals. And then at 6 weeks after, there was improved numbness in her genitals and buttocks. And then she had normal urinary function, and then no significant pain at all. And so people tend to do really well with these decompressive surgeries, even if they have very significant symptoms up front. Sorry. And this is just that other paper that says that, within the first 3 days of injury, you can predictably have good neurologic recovery, whether it's Cauda-Equina syndrome or this other syndrome, conus medullaris syndrome. I'll talk about one more case, and I'll kind of open it up for questions. But this case is about an interbody fusion for spondylolisthesis and degenerative disc disease. So this is a more complicated case requiring instrumentation, but this patient was a 70-year-old male with chronic back pain. He had 5 to 6 months of left foot weakness, numbness. and now had low back pain since at least 2018 with sciatica down the left leg. Um, he also had stiffness of his left leg. The pain was radiating from his low back down the back of the left thigh to his calf and the top of his foot with associated numbness tingling. So, because he was having this worsening weakness of his foot, the fact that it had not gotten better over many months, the patient decided to go for surgery. There was weakness of left ankle dorsiflexion and EHL extensor houses. It's basically the great toe extension. And then there was some diminished sensation. He was basically favoring his right leg. And he had a nerve conduction study that showed left L5 radiculopathy and a left S1 radiculopathy. So two different nerve roots were being pinched in his case. And you can see the top is the MRI um, from a couple months before the lower MRI, and it looked okay. And then he started declining over several months. And that's when you see that L4 bone slipped forward on L5. There's worsened disc herniations at several levels. And then there's spinal stenosis. And then there's also a collapsed disc at L5. And this was treated with a fusion surgery at L4 to S1. And where we clean out the disc and we open up the space, and you can kind of see the bones at the level above and below the fusion in the back, whereas the laminectomy was done here. And all the nerve roots were kind of opened up, especially on the left side. The nerve roots were freed up and the spinal canal was freed up. And he improved. He had no back pain or leg pain at 6 weeks. He had persistent weakness in the left ankle because it had gone on for so long. Took a while to regain some strength, but his sensation in his legs were improved. And then at 6 months, he had no back and leg pain, but he had still some weakness there, but it was continued improvement. It was continuing to get stronger with physical therapy. Now, this case had some spondylolisthesis or a slipped bone, and we corrected that a little bit. As you can kind of see, the bones are in much better alignment here. But making that decision whether to pursue instrumentation and fusion or just do the decompression was kind of a critical point that we talked about in the office. And the patient elected for a more definitive fix of the problem, allowing us to be more aggressive at bringing up the space around the nerve roots. So this paper is kind of shows, it's not in contradiction with what we did, but it shows that decompressing the spine alone was non-inferior to decompression with fusion over a period of 2 years. And so it argues that sometimes you can do a decompression alone, even without the fusion, and still get a good result. And so that's a really important part of the conversation, is whether to just do decompression or whether to include this instrumentation. We usually go into that in detail, why we might do that or why we might avoid doing that in the clinic. Okay, so these are just a couple other cases where this is a patient who had prior surgery, and then she had some breakdown at the level above, and she had a nerve root pinched at the level above, and so she needed her surgery extended up one level. And the point of including this type of case is just that when we do fusion, it sets you up for needing a fusion down the road. Because whenever we put instrumentation in, at 2, 5, and 10 years, you're going to have an increasing need for either having radiographic degeneration of the next level next to where the instrumentation is, where the screws and rods are, increasing symptoms. So at 5 years, there's about 15% of patients who are symptomatic of the next level being degenerated. And at 10 years is about a third of patients. And fewer number, but still significant, 10% at 5 years and 15% at 15 years require surgery. But that tells me a lot of people are getting away. You do a one-level fusion on a patient, and then after a certain amount of time, a lot of people are getting away without needing another surgery. On the other hand, if you give that person a fusion and you give them enough time, you're probably going to break down. You're probably going to wind up in a situation where you would benefit from a surgery. And so it's just something to be taken seriously. Anytime we consider doing fusion, we really need to, that needs to be a great benefit to you, because we're setting you up for in 5, 10, 15 years needing further surgery. And I'll stop there and open it up for questions. And just want to leave some final thoughts, that low back pain and leg pain come from a variety of sources. And then in the clinic, we work together to review the potential benefits and pitfalls of non-surgical options and surgical options, and tailor the right surgery for the right patient. In your case, we find out what your specific problem is and what type of non-surgical or surgical solutions are going to help you get better, get you back to living life the way you wanted to live that life. I'm checking in the chat. I don't see any questions at this time, but please send in your questions if you have any.
Dr. Sursal, there's some in the Q&A at the bottom.
Taking a look. I don't see it right now. Maybe it's because I'm there. I see it now.
Okay.
Great. Okay. Uh,
Oh, they're coming in now. They're coming in.
yeah,
Chat.
I see it now. So I'll start going through these. It's one person says, my second opinion says same thing, lumbar fusion, 3-level surgery. What say you? Yeah, that's a great question. Unfortunately, without looking through your imaging and seeing your symptoms, I won't know. But it's often good idea to seek second opinions. I don't think any of us are offended when people seek second opinions, and sometimes it gives you a chance to hear the same advice from a different perspective, someone who's maybe wasn't involved in your initial workup, and somebody who's maybe comes at it from a different point of view, and maybe shows you that the same recommendation, or maybe just explains why there's a spectrum of recommendations that are reasonable. And so it's good to get a second opinion. But I'm happy to look at your case and see what kind of surgery you might benefit from or not. And then this next question I'm reading here, does hanging upside down help decompress the spine or alleviate lower back pain? That's a really good question. Some people do find this kind of maneuver helps, and some people go to chiropractors or physical therapists and get some kind of decompressive stretching, hanging upside down. And I don't particularly believe in it. Now, there are people who've come to see me and they say, it made me feel great. But the way I think about it is you stretch out the spine, and that may help temporarily while you're doing that stretching. But once you're back on your feet and upright, those spaces where the nerves are, the space just collapses back down. And so even if it helps you feel better, it's very likely to get re-irritated again. So it's not a fix for the problem, but it may temporarily help you feel better. I hope that helps answer that question. And then it says, why not do disc replacement versus fusion? It's almost 2026. That is a great question. I love that question. I don't know why not. So we haven't had great success with lumbar disc replacement. Now, if you talk to people in the industry, they may say, oh, it works great. You may talk to some person who has a specific population of patients who does well from it. But in the data that I've reviewed, there hasn't been a great solution with disc replacement in the lower back. I have seen some promising new technologies that may be beneficial in the future, but they're untested yet. And so what we're looking for is disc replacement or total joint replacement, some kind of technology in the lumbar spine to continue to give you that mobility rather than fuse you. What I've seen is that often people lose mobility in their lumbar spine, and it does set them up for the risk of having adjacent level disease, like I talked about before. But they kind of are okay with that trade-off for the pain relief or the symptom relief, or solving the problem that they had at that time. But that's a great question, and I hope we make some headway on that front. I haven't seen it be promising in the lumbar spine yet. And the cervical spine's a totally different thing. In the neck, we do disc replacements with great success, and I think it's a fantastic surgery, and it really helps patients a lot. I haven't seen it be great effect in the lumbar spine. Next question I see here is, how dangerous are severe nighttime foot and big toe cramps in somebody who has severe L4-5 stenosis? Well, that's a hard question to answer. I mean, I think the cramps aren't dangerous themselves. It's a sign that there's some kind of pinching of those nerves. And um, the question is, are we injuring those nerves, and is that going to become a permanent uh, problem for you, even if that gets decompressed at some point? Usually, when you take the pressure off the nerves, all that cramping stops. Um, but if you have severe, for you, if it feels severe, then it's really affecting your life. It's probably keeping you from resting at nighttime, and getting good sleep is also important for your health. And so it's time to seek some kind of therapy for it. Whether it's surgery or not is another question. But I don't think the fact that you have cramps is dangerous in and of itself. The things that are really dangerous are loss of bowel bladder control, profound weakness in the legs, and certain types of sensory loss, like in your genitals in that area. So I hope that answered that question. But it is a difficult question to answer because it very much depends on the specifics. What's really going on? How long have the symptoms been going on? Does it get better with any kind of change in your activity or treatment with medication? Um, Another question here. It says, often an older person has both hip and lower back issues. How do you determine which should be addressed first? That's a fantastic question. And I don't think there's a great answer to that. Usually what we do is we evaluate both of the things when we think there's two problems. And I see a lot of patients with back problems that come back and that see me in the office, and I notice that they also have a hip problem. I'll often start the process of working up the hip and refer them over to a hip specialist. And then the two of us will discuss what we think is going on and whether one is more urgent than the other. And, for example, if the hip needs to be replaced, sometimes they want us to treat the back first so that they can do rehabilitation after the hip replacement with better success than they would if they still had the back problem. And other cases, the joint is completely collapsed, and it's really important to just get the hip fixed right away. Uh, I saw one case with an infection that was like that. The hip joint was infected, and therefore that had to be treated first before the back was. So it's not always easy to determine which should be addressed first, but the general way we do it is we work as a team, collaborative team. And at Jordan Young, it's great because our orthopedic colleagues are just across the hall from us, and we're able to talk about, refer and then confer with each other about this type of situation where there's two problems in the same patient. What percentage of people have to have instrumentation? I don't know the answer to that question. That's something I can look up and try to get back to you. But it really depends on what your specific problem is. I think the problem I have of answering that question is I need to be specific about what group of people we're talking about. For example, if we're talking about people with lumbar spinal stenosis, it's probably a small percentage of that whole population. But if we're talking about people with excess mobility, excess movement on their flexion extension x-rays, it's basically 90 to 100% of those patients need instrumentation. So if there's gross instability, or the stenosis is so bad that we're going to have to remove enough bone that we, in doing our decompression, are going to cause instability, then we have to instrument them. So I don't know the percentage of people. I don't know how to answer that question, but I can try to get back to you about that. Let's see, got another question here. Can I do surgery with scoliosis? 88 years old, very healthy person with recent inability to manage pain. I mean, it's not the age that's the problem usually at 88 years old. One, that's one factor. Usually the age comes with a number of other medical issues, including usually some bone health issues like osteoporosis. if you're an 88-year-old that's very healthy, no osteoporosis, and no big cardiac issues, something like that, then I think treating scoliosis is not necessarily unreasonable. But I would make sure that you've tried every other strategy to manage pain. One reason not to do big scoliosis correction at an older age like that is that the recovery can be quite long. It's not just 6 weeks or 2 or 3 months, it's 6 months to 2 years, and that may be quite a significant amount of time to be recovering. And it may bring you back function, but it may also come with its own risks. It's a big surgery, and it very much depends on that if you're truly a healthy person and you don't have any other complicating factors. Um, but yeah, I think the age alone is not the only thing. It's these other factors that have to be evaluated in the clinic. How do you use the bathroom after surgery? Well, that's a good question. You know, uh, be- there shouldn't be anything after surgery that prevents you from using the bathroom. You usually have a dressing over your wound, so as long as you keep it clean, um, that should be all fine. There can be some trouble. You may have some trouble bearing down because it may trigger some back pain, but um, that's why we give you stool softeners to help keep things light and easy, so you don't have to bear down too much. Let me see what else is there.
There's also questions more in the chat.
Okay,
Yeah.
take a look there. Gotcha. Okay. I saw the why not do disc replacement versus fusion. How likely is that I'll be able to get a diagnosis after initial MRI? Well, very likely. So part of what you do in the clinic is we talk about the history of um, your condition, and then we talk about what you've tried to manage your symptoms, and then the MRI shows us the nerves and the joints, and most of the time you're able to find out the reason for the pain and the symptoms that you're having, but it's not always 100% clear. In the cases where it's not clear, we go for other testing. But in general, the MRI is very telling in terms of where the symptoms might be coming from. And look, if the MRI shows nothing and everything looks great on the MRI, that usually means that it's not something that surgery can help, and that other methods, whether they're medications, therapy, or injections, are good for treating. This is a good question. What is recovery like for a laminectomy? So if you've been in my office before and talked about recovering from a surgery, you may have heard some of the things I'm about to say, so apologize for that. But recovery from a laminectomy is pretty good. You typically have a period, it's either a same-day surgery if it's like a one-level laminectomy, or it's an overnight stay. And that depends on your particular circumstances. Your incision heals over approximately 10 to 14 days, at which point we take out the staples, and maybe it's still healing over that third week. But usually by then, your incision should be healed. The muscles have to heal over a little bit longer periods, approximately 6 weeks for those muscles to kind of heal and scar together. And so that's really kind of when you see me again afterwards, um, uh, when I relieve all your restrictions. So you have restrictions for the first 6 weeks of no bending, lifting, twisting movements. So no lifting over 20 pounds and bending over at the waist or twisting movements. It's pretty common after back surgery to have those kinds of, avoidance restrictions. And so, you're supposed to be up and walking immediately that day after surgery or the day of surgery, once you've recovered from the anesthesia. But you may have some soreness in the lower back, and that soreness will get better over the first couple weeks to the first 6 weeks. And then you'll be at your new normal at about like 2 months, 2 to 3 months, depending on your condition, like how bad you were beforehand and how quickly you recovered after the surgery. Hope that answers that one. Um, would you recommend dry needling through physical therapy for low back pain? Yeah, that's a good idea. It can be helpful for some people. Some people can't tolerate the dry needling. Other people swear by it. It's basically another tool in the toolkit for low back pain. People do acupuncture, people do massage therapy, people do hot and cold therapy for their back. Um, so, you know, dry needling is pretty reasonable. Do you do premium spine top surgery? I don't know what that is. I'll look it up, but I don't know what that particularly means. Do you do endoscopic surgery for spinal stenosis? No, I don't do endoscopic. I do minimally invasive, but I don't use an endoscope. Um, eh, in general, I didn't necessarily emphasize minimally invasive versus open surgery in this talk, but the general idea is when you do minimally invasive, you're disrupting the tissue less, but it's very focused. So if you run into a problem, you have to bail out to an open technique anyway. And so one of the problems with doing endoscopic surgery is that there's a higher rate of bailing out to an open anyway. Some surgeries are also done well with endoscopic surgery, and other ones may need an open surgery anyway to be done properly. And we could talk about that in the clinic. What is the typical recovery time for decompressive surgery? I think kind of went over that before. Basically, 6 weeks is sort of like that initial recovery time, but you're up and walking the next day. It's just a matter of, the first couple days there's going to be some back pain, and then it'll get better with time. By 2 months to 3 months, you're kind of back at your new normal. Patients, someone says, I have pain in around T9 and T10. Is the treatment basically the same as it is for low back pain? Well, the question is, if you have back pain around T9, T10, and you don't have any radiating pain that's going around your flanks, or you don't have any leg symptoms, leg weakness or numbness, tingling, then it depends on what the source of the pain is. Usually, you'll get some kind of imaging, like an MRI or X-ray or CT, to see whether there's a fracture there, and try to identify why you're having pain at that region. If the MRI just doesn't show anything, then it may just be musculoskeletal, and you may need physical therapy as a way to try to, and pain medication management as a way to try to manage that. But if there's some facet joint arthropathy, sometimes you can try injections in the facet joints to see if it helps. And ablation may be a useful adjunct after those injections are helpful. But yeah, it's an interesting question, but it really depends on why you might be having pain around that area. Someone says, I have congenital spondylolisthesis, original surgery 1979, but now my symptoms are back but different. Would a revision be advised? Yeah, well, it very much depends on your symptoms. It's not uncommon to have a surgery, like a fusion surgery, and then have adjacent level disease. And as you saw, sometimes you have to extend the fusion up a level. And so what we usually get is we get either an MRI or a CT myelogram to take a look at what we suspect is an adjacent level degeneration, where the next level the disc is worn out or the joints have worn out, and see what benefit you might get from a revision surgery. If it's really the exact same symptoms, then that's a different question. But if it's new symptoms, it's probably a new nerve root that's affected, and it's probably the level above or below. Okay. Often an older person has both hip and lower back issues. How do you determine? Oh, yeah, we talked about that. Hope you heard the answer to the previous question about hip and low back issues. Can I make an appointment with you through the Jordan Young number? Yes, you can. In fact, here, I'll just put up on the screen is a number to make an appointment with us at. You can call and schedule an appointment. I have tried every modality and don't want a fusion, but would consider a facet joint TOPS procedure. Yeah, if this is the procedure I'm thinking of, the one that was mentioned before, if it's the one where they basically fuse the joint, it's not really certain that would help you. And then you might end up needing a fusion if they have to take that out at a later time. But a fusion may not be the right thing for you in the first place. So it really, as I was mentioning, depends on what the MRI shows. And then if it's the times when a facet joint TOPS procedure, this kind of like a local fusion would be beneficial, is really only when you've identified that that one joint is the one that's causing all the pain. Um, and so that's not always easy to do, but you often get referred to a pain management specialist who may do a facet joint injection. And if it's that particular joint that improves and it's unstable, then one of these like joint fusion procedures may be beneficial. That's actually quite rare. It's not usually what's causing the symptoms, and there's usually other things that are going on. So to answer that question, it's that it very much depends on the specifics of what's on your imaging. Um, and yeah, maybe a fusion is not the right thing for you. But facet joint tops may not be the right thing for you either. So I'd have to take a look at your imaging, and we'd have to talk about what to do. If you have undergone a decompression laminectomy and have had minimal symptom relief after 18 months, what would be a logical next step? Um, yeah, if you haven't improved after a decompressive laminectomy, that's a tough one. One thing is you probably need to get new imaging to see whether you were adequately decompressed in the first place, whether they basically gave your nerve roots enough space the first time. And if that was not the case, then maybe you need a bigger decompression. If that decompression was as big as they could go in the first place without destabilizing you, it may be that you need a fusion with decompression. So I hope that helps answer that question. Um, Microdiscectomy of L5S1, removed some disc in 2020, extreme active, back pain's back, heavily considering disc replacement versus fusion due to not wanting to lose mobility, return to the table, 43. Yeah, being young is difficult especially when you need a fusion, but it really depends on, again, what does the imaging show and what is the specific problem that you're having. If it's a recurrent disc herniation, you could always have another discectomy. If it's a problem of instability, then the fusion may be helpful. But you need to talk with your surgeon about the imaging and what it shows and whether if it's the same symptoms and there's a recurrent disc herniation, you may just need another decompression. If it's truly unstable or recurrent after a second surgery, then a fusion is probably the right way to go, and a disc replacement is probably not the right way to go. But yeah, it's a very interesting question, and I agree. When you're 43 and you get fused, you have a lot of time to develop degeneration at the next level. So it's a tough question. Um, are back braces used after surgery? If so, which surgery results in needing one? That's a good question. Some people decide to use them. Some people don't use them. Um, I don't typically give it to everybody that I do a back surgery for. Some people I definitely give back braces for are people, for example, who I'm worried about fusing. Maybe they have osteoporosis and their bone health's not quite that great, and I use a back brace in those cases. I use cervical collars when I do cervical fusions to help give comfort and be a reminder that you just had a neck surgery, and to help the healing start in the right alignment. But some lumbar spine surgeons use back braces with all of their fusions, and it again serves the same purpose of kind of protecting your back in that first couple weeks after the surgery, getting you healing in the right alignment. But it's not necessarily needed for everyone. But one risk of using a back brace is that you decondition the muscles in your core and your lower back that may benefit from or that you need to keep you upright and keep. And so if you decondition those muscles, you potentially rely on it may put more stress on your back surgery. So there's pluses and minuses of using back braces. Some people use them a lot and some people don't use them. It's not a clear cut answer there. Certainly, if you're unstable or the surgeon thinks that you need extra stability to heal properly, they'll give you a back brace. I am scheduled for surgery. Pain in December 3rd. Pain was first in the left back, leg, foot. Past couple months, the pain has greatly developed in the right leg. Do I need to tell this to the surgeon? Absolutely. Um, one of the first questions I usually ask when I see a patient on the morning of surgery is, have there been any changes since I saw you in the office? And if the pain is now moved to the other leg, it may be something that requires an update to the imaging. It may not. It depends on whether that was expected. Maybe the prior imaging showed that there was some narrowing of the nerve on the right side. Sometimes what happens is that you have so much discomfort in your left leg or one of your legs, and then you start compensating by using the other leg abnormally, and therefore you develop a pain in the other leg. Whatever the reason for it, tell your surgeon, and then they can figure out whether to get updated imaging or whether they just need to be more aware of what to look for when they're in the surgery, or whether it maybe is just expected based on what your previous imaging showed. Oh, what can family expect after their loved one has surgery? This is a great question. After surgery, the patient will have soreness in at the level of their surgery, especially in low back, and it can be difficult to get up and do your normal daily tasks. Um, it, you know, it can be something that is challenging if you don't have any help at home, especially in that first week or two. Certainly, the first day after surgery, you're recovering from anesthesia, you're on pain medications. You probably want someone around, at least just to be of some assistance in case you need something. But after the first couple of days, it may just be useful to have a little extra help around the home. Everybody has chores and things they need to attend to on a routine basis. And, having a little extra help, especially with things like heavy lifting, bending and twisting, some of the household chores that require those kinds of movements, people will need some support for that. But then, there's a lot of other little details like um, the healing of the incision, need for getting refills on prescriptions, getting to appointments. You may need someone to drive you to the appointment if you're not ready to drive yet for whatever reason. And so the family can expect some pain and some pain control issues in the first couple days after the surgery, especially where the incision was. Um, but that should gradually get better with time. Is a laminectomy done as an inpatient or outpatient procedure? So it's an outpatient procedure, but I don't have any problem keeping people overnight for a day or even 2 days if they need that extra time. Or for example, if you live quite a ways away from the hospital, and going home would be a problem if you had some kind of emergency, then we might keep you overnight so that you have a day to kind of get a sense for what your pain is going to be like post-op and what it's like after you've had the surgery. Um, in the hospital, whether it's you're leaving on that same day of the surgery or the following day or 2 days after, you usually work with physical therapy and occupational therapy to get a sense for how it feels like to walk up and down the halls and move around. And if you have stairs at home, how to use the stairs. So the laminectomy is done as an outpatient procedure, but some people I keep overnight and some people I discharge on the same day. If it's a multiple level laminectomy, I usually do it as an outpatient procedure, but you stay for basically a day or two. Um, if I feel the need to put in a surgical drain, then you often stay a day or two for that drain to finish draining and then comes out. The next question, patient with a 3-level fusion from L3 to S1, if revision surgery is needed to disc above, can the original hardware be removed since the spine is fused? Yes, it can. And I saw a patient the other day that had a previous L4 to S1, and then they had their current hardware was L1 to L3, and they had had their prior hardware removed because the previous surgeon thought that their spine was fused. Um, so there's a couple ways to answer this question. Yes, the hardware could be removed since the spine is fused, but sometimes it's not a great idea. Sometimes when you remove the hardware, you find out that the bone was relying on that extra stability from the screws and rods. It wasn't just the bony fusion that was giving support, but actually the spine needed the hardware in there. And so we don't typically do another surgery to go in and remove um, the original hardware, especially for an L3 to S1 fusion. Um, usually what we do is we connect the old fusion hardware, the old instrumentation to the new level. And whether that's with hooks or with end connectors or just replacing the rod into one longer rod, there's different techniques for doing it. But um, yeah, I hope that answered that question because yes, in some cases the original hardware could be removed. It's not always recommended. And usually it's best to leave it in place, especially if it's as long an instrumentation as L3 to S1. Uh, Another person says, when I had my original Fusion 1979, no instrumentation was used. That's right. Sometimes we, especially in the older days, we did Fusion without instrumentation. The instrumentation nowadays is very helpful for stabilizing it while that bone heals. We get better fusion rates because we use the instrumentation. My daughter's surgery 2017 has instrumentation. Do they do surgery without instrumentation for spondylolisthesis anymore? So not usually, but sometime. But you'd probably find some attending surgeons who come from a time where they did more fusions without instrumentation. But the current teaching, I haven't, I didn't see anybody during my entire training that treated spondylolisthesis with fusion without instrumentation. Um, Other conditions, I did see some fusion without instrumentation, like a decompressive laminectomy, and then they fuse the adjacent joint. But I didn't see spondylolisthesis being treated with fusion without instrumentation. But it's an interesting question. Actually, you could have a whole talk on that. Um, okay. I had help with my sciatic by being treated with Almar. It's an electrical type stimulation approved by FDA, but not paid by insurance, very much like a TENS unit. Got done locally, but done at big name hospitals like John Hopkins, Mayo, et cetera. Yeah, there is some electrical stimulation for nerve root pain. Uh, and what can I say? There's lots of adjunct methods and alternative methods of treating nerve pain that aren't surgery. And so I try to get people to be connected with whatever different types of techniques might help them. I personally don't, do this kind of electrical type stimulation, but I send you to physical therapists and to pain management specialists who are experts in these other types of modalities. And if they think you would benefit for something like this, they would probably recommend it. I don't know if anybody locally has those, but that's an interesting comment. Yes, I'm aware of the treatment, but I don't know if how many people are doing it in this area. Who's a good candidate for an ALIF? What symptoms do they possess? An ALIF, is just another way of doing the interbody fusion. Patients who have foraminal stenosis because the disc space has collapsed, they may have pinched nerves on one side or both sides, back pain, and their imaging reflects that there's no central canal narrowing. It's just where the nerve roots are coming out, and that the pain is mainly from the collapse of the disc space in the front and and from the narrowing of the foramen on the sides. And so ALIFs are often best done at the lower levels at L4, 5, and L5S1 especially, and they can help restore a lot of the normal lumbar curvature that you have. It's what's called lordosis, or curving backwards in the lumbar spine. And ALIF is a great technique for restoring that lumbar lordosis that you may lose from the collapse of the disc height. And so the patients who I usually refer for ALIF are patients who would benefit from that kind of therapy more than they would benefit from a posterior interbody. I'm in next person is I'm in therapy and it has been for 9 weeks or more. Right after therapy, I'm fine, no pain, can walk upright, but it doesn't last long. No long time sitting, walking, lying down, or standing. Yeah, I mean, I guess it turns out that some of the things they were doing in therapy was helping. And so it may be an argument for continuing the therapy, doing more of their exercises at home without the therapist. That's what's, I think, nice about having a therapist and having a coach in that sense, is being able to have somebody point you in the right direction, give you exercises. What this kind of your symptoms coming back after the therapy tells me is that there's some underlying problem going on in your spine that is anatomic, that probably you know could be um, altered with surgery. The question is, what is it, that kind of anatomic abnormality that's causing your symptoms? And is surgery the right thing for you? Or do you need some other modality like medications or injections to help? Um, Next step is to get relief with my back. I had a full hip replacement this past April with Dr. Marshall. Hope that went great for you. Um, and anxious to get started. Well, I look forward to meeting you. Um, is RFA, or that's radio frequency ablation, a good solution for L5 stenosis? No, it's not for treating stenosis at all. But radio frequency ablation is for treating back pain from the joints. So if you have overgrown joints at L5S1, and that's a source of your back pain, then the radiofrequency ablation may help with your back pain. But the stenosis at L5 may cause leg symptoms, numbness, tingling, trouble with your walking, leg pain, and the radiofrequency ablation won't help with any of those nerve pain symptoms. It will help with back pain, hopefully. I'm a PT physical therapist of 15 plus years, and I've recently seen two cases where I believe the whole L451 fusion has downslipped, as we say in manual therapy. In both cases, I applied a superior glide from the inferior sacrum, thinking I could normalize the levels above the fusion by approximating the tissue. It seemed to help immediately on both people. Not sure if it will last at this point. Do you see a large gap when you operate on these patients in the levels above a fusion, particularly fusions involving the sacrum? One of the reasons to go down to the sacrum is to sort of anchor the fusion to the pelvis in some way. And sometimes we even put in pelvic screws to anchor our fusions down to the bottom. When you're talking about this kind of the spacing of the joints or the bones above where the fusion is, that is something that as surgeons we're trying to optimize, the angles that we're leaving the bones in when we put in our hardware and fuse it and apply the pressure to the rods. And then we're trying not to put too much stress on the joint above, and we're trying not to put the spine into a bad alignment, which is more likely to result in needing more fusions in the levels above. And I have no doubt that some of your manual therapy could really help some of the patients like at that adjacent level. It's just a matter of whether that will be a permanent change. Um, and yeah, it's a really good question. And unfortunately, as once we fuse somebody, I think it's just a matter of time. I don't think it's something that we can necessarily prevent with therapy, but it's something maybe we could ward off. Potentially. I think I answered this last one. And then here we go. Does genetic ankylosing spondylitis disease lend itself to lumbar surgery? Yeah, good question. So ankylosing spondylitis, for those who don't know, is sort of where you get a bamboo spine, where you have sort of this inflammatory change that heal the bones together. And your spine becomes more brittle because it can fracture easily because it's one long rod. The same way you would take a stick in your yard and you might break it because it's one long rod. The spine tends to be flexible, but with ankylosing spondylitis, it becomes inflexible and therefore becomes stiff. Um, you can't cure spondylitis with lumbar surgery, but it often leads to things like lumbar spinal stenosis or foraminal stenosis that may benefit from lumbar surgery. So I hope that answers that question. Ankylosing spondylitis is not a friend to people's backs. It really can cause a lot of back pain. It can also create a lot of conditions which make you more susceptible to injury. So, you know, that's what I'll say about that. Are cramps in either lower extremity usually nocturnal, something that can occur after an extruded herniated L4 that resolved at performance of PT? So, yeah, it's a question. So I'm not sure I fully understand. When you have a herniated disc and it's pressing on a nerve root, you can get cramps in the lower extremities. And then if the pain that you have from that herniated disc is resolved, you may still have nerve compression that's still producing cramps. It may take longer for those cramps to improve, um, or you may just still have a pinched nerve there. So that may be what's going on. Hard to tell, but yeah, that's an interesting question. I think you might take a look to see with new imaging whether that disc is really resolved or not. Taking pain medication does not help at all. Yeah, yeah. Unfortunately, many cases, pain is really difficult because everybody responds to pain in a different way. Some people have surgery, for instance, and have no pain at all, very little after surgery, and some people have the same surgery and have extraordinary pain. And like the same is true of people who have a pinched nerve or arthritis in their lower back. And some people respond well to pain medications, and some people it doesn't really help very much. And some people need something else, whether it's therapy or heat or electrical stimulation, or whether it's injections or radiofrequency ablation or surgery to try to treat the pain. And sometimes what you hear from the surgeon is that I don't think surgery is going to help with your pain. And that's not a fun thing to hear, but I have had people be disappointed when I tell them that in your particular case, I don't think surgery is going to help with pain. And so that's always hard to hear, but we're surgeons, and we want to do the right surgeries for the right patients. And if we're doing too many surgeries, we're going to hurt people. And so it's actually, to hear us say that we don't think surgery is going to help you, we put a lot of thought into that. Do you recommend surgery versus acupuncture? Well, look, I mean, if you get better with acupuncture, just do acupuncture. I mean, surgery's a little extreme if you're feeling okay with some, Tylenol and acupuncture. But if you know, acupuncture is not necessarily a curative thing. It may treat you while your body is healing. So in certain conditions, your body may heal with time, and in other conditions, your body may not be likely to get better. For example, in degenerative lumbar spinal stenosis, where your spinal canal is narrowed because your joints have overgrown, your ligaments have overgrown, acupuncture may treat your back pain, but it's not going to treat the stenosis. It's still going to be there and still going to continue to cause problems with your legs and your back. Can you put up the slide with the nerves that are affected? Slide 1 or 2 again. Yeah, let's take a look at that. These are some pictures of like the nerve root distributions. I don't know if this was the one that you were talking about or whether this was the one you were talking about. This is kind of a nice picture, but maybe you were talking about this one. And hopefully these slides are available to you afterwards as well as this talk. I think I'll answer 1 or 2 more and then we'll wrap it up here today. I wish I had time to answer all of your questions. Um, is there ever a point of no return, meaning you waited too long with scoliosis, stenosis, compression, arthritis, and your lumbar spine is so damaged that nothing can be done? Well, yeah, that's a difficult question to answer. I have seen some patients who are so far gone that this type of surgery they need is so extensive that their health prevented them from getting, you know, a treatment that might be beneficial to them. In which case, there are some kind of treatment methods like spinal cord stimulation that can help with pain, even if they can't fix the problem. I think one good way to tackle that is to see a specialist, hear what they're recommending, and then follow up with them routinely over a period of years to see how things are progressing. If you're doing fine, then you probably don't need surgery. But at some point, there's probably a transition point where you might start doing worse, and you'll have already been plugged into a specialist that can help treat you and catch things kind of on the earlier side. That way you don't reach that point of no return. I think the point of no return is when you can't tolerate the surgery to fix the scoliosis or the stenosis or the compression. Usually with single level decompressions or stenosis, there's really no point of no return except when there is nerve damage. And then even if we undo the compression, um, nothing can heal that nerve. In a sense, when we do a decompression, we give the nerves space, the spinal cord space, and then this body has to heal. And there's nothing more that we know how to do to make the body heal or not heal. We just give it space, and try to calm down whatever inflammation's in that area. So the point of no return is if the nerves are too far injured or you cannot tolerate the surgical intervention that's required to fix you. So I'll take one more and then I think we'll wrap up. Does TRICARE, okay. I can't answer questions about insurance. You know, I hope they do. It'd be weird if they didn't, you know. Um, but I don't know specifically what insurances cover what. Every insurance company is different about what they. Does ablation help in some cases? Also, what is Bastrps? I don't know what Bastrps is. I'll have to look that up. But ablation does help in some cases with back pain, not necessarily with nerve pain. Okay, I think that's okay. Um, Thank you all for coming. I really appreciate a chance to be able to chat with you all and give you a sense of what it's like to tackle some of these problems and hopefully give you some ideas. Yeah, if you'd like to speak specifically about your own health, then I'd be happy to see you in the clinic and review your imaging with you and talk about your history and go over everything.